could be reversed by controlling these. So 80% we heard earlier, in this trial it was as high as 90% could be reduced by removing these attributable risks. We look at the pooled cohort trial, which is what we base our ACC-AHA guidelines on today, shown here. Here's the calculation of the formula from the combined pooled cohort of major NIH trials that were done. And if we look at the parameters in there as well, total cholesterol, HDL, systolic blood pressure, all important variables. If we control those, then we reduce the incidence of cardiovascular disease in that population. So we do know the way to do it. We can reduce 80 to 90% of these cardiovascular events that we're left with. If we look at primary prevention, that's an important aspect to go as well. What I have here in blue is the healthy lifestyle for individuals, and in pink, those are the groups in the ACC-AHA guidelines for reducing cardiovascular disease as primary prevention. Obviously, you would want to treat diabetics and very high LDLs over 190. Those are the recommendations for that. For the intermediate group, there is a recommendation shown here in pink of statin therapy as well, with the rest having lifestyle modifications. But as you see, there are individuals we talked about earlier today who are younger, who don't have all these risk factors, who come out with a myocardial infarction or stroke, and we would like to consider how we can further prevent in that patient population those events. So what can we look at? Well, let's look at going beyond the standard treatment of that is individuals with an LDL over 190. Let's consider lowering the treatment goal in individuals without existing disease to 160 and then going down further to 130 in that patient population for that. And if we then look at individuals or treating any individual with a risk score of greater than 5%, we're going to be adding patients to that patient population. The current standards would recommend treatment in 35 million of the U.S. individuals. Expanding or lowering the LDL target in primary prevention would add up to an 11 million population for that. What would that get us? Well, if we do simulations for that, what we can see is by lowering the LDL from the current guidelines of 189 down to 130, we pick up a lot of groups shown in this simulation for that of over 1 million patients. And what we can see is in many of these categories, for men and for women, these issues show cost savings. So we actually save costs, not cost effective. It actually makes money by treating these individuals with statin at an earlier period or a lower LDL. So lowering the LDL from 189 down to 130 is going to save us money and save lives and complications as well in men and in women at that point in time. This is allowed under the guidelines, but it is a 2B category or recommendation. Our recommendation at this time would be to go forward right to the 2B and save those individuals. What would we save with that? We treat 11 million more individuals. We'd save up to 5,000 events per million individuals that we have. That's a 0.5% million reduction at that point. That means that if we, in fact, treat them for 10 years, we'll save about 5% absolute risk. Number needed to treat is about 20 to save one life, but we're saving one life or event, and we're saving money at the same time. Not cost effective, meaning it costs us so much. It costs us nothing to save that life. We make money by saving that life at that point in time. It's a very important aspect to go for. And so what we're expecting at this point in time is we expand the pink area here of treatment that you see from diabetes in very high-risk individuals with high LDL to a lower LDL. We push the LDL down to under 130 and treat anyone who has an LDL over 130, whether they have borderline, intermediate, that were high risk at that point in time. And we actually save lives and money at that time. That's an important aspect. Now, for those who don't tolerate a statin or don't want to take it, we have another option, and that is to do pulmonary calcium CT scoring at that time. And what that can identify is those individuals who really, really need that treatment. You can see if your calcium score is 100 or higher here, treatment with a statin significantly lowers your event rate, as you can see here, from the blue line down to the red line. Treatment of a calcium score of 100 to 400 is highly effective in reducing your event rate. Similarly, if we look at a calcium score over 400, treatment with a statin, highly effective, starting very early on at reducing your event rate. However, if your calcium score was 0, you can see treatment with a statin, really no benefit at that point, and a calcium score of 1 to 100 is a minimal benefit at that point. We clearly need to, if we find an individual with a high coronary calcium score, get them on a statin for benefit at that point in time. And if they are in one of the earlier treatment groups and their score is actually 0, we have a warranty of anywhere from 3 to 10 years where we could wait and treat them with a statin at a later time at that time. So if we look at cost effectiveness in our treatment of statins for borderline risk, treatment for a lower cholesterol, dropping it from 189 to 160, is cost saving. We make money. Lowering it further to under 130 in that population is also cost savings in all men and highly cost effective in women at that population. Save money, save lives, save events in both of those populations. And for those with a coronary calcium score of 0, they gain little benefit at this time from statin. We can wait or delay their statin therapy. Personalized treatment using both of these can save lives and reduce costs at the same time. Two very important things for our population as we go ahead. That was with cholesterol. Looking briefly at blood pressure, we have similar findings that we can show with blood pressure. In the SPRINT trial, they looked at intensive therapy, dropped blood pressure under 130. So the guidelines or the numbers we showed earlier were how many patients make the line of 140. We're actually saying we should push that a little bit further in higher risk individuals to down to under 130. What can we do with that? Well, it's easily done, shown in the SPRINT trial. They quickly went from standard blood pressure 136 treatment down to 121 in the intensive group. What did they accomplish with that? Well, obviously they put all of those individuals who had some risk factors and who were older on medical therapy, showing pink here in that treatment group, and that was in fact very effective. It lowered events, as you can see in the group, significantly. Number needed to treat was 61 with that group. And if we focus on that lowering of event rate in that patient population, we see an absolute risk reduction in the events of 0.54%. And that is 5 events per 1,000 patients. If we think of 10 years of treatment at that, that's again another 5% individuals. Number needed to treat is 20 if we're going to treat them for 10 years in this patient population. Prevent death, prevent MIs, and prevent strokes in that patient population. We do have ways of reducing blood pressure. Patty mentioned earlier that her mother was a code breaker in World War II. You may remember in World War II we had an individual, FDR. He died of hypertension because we did not have any effective treatments at that time. We now have multiple effective treatments for hypertension. We need to make sure we proceed with that. And if we look at the numbers globally, we can see that further lowering the blood pressure goal from 140 to now under 130 would save approximately 40 million lives globally for that. So it is effective in both men and women at that point in time. And to, in fact, emphasize this, Hattie asked me to make it simple and that we could actually remember it. So we do have a way of doing that. put this down for a second. And this is, how do we remember those numbers? Now, what we see here is that there are aspects of this lower number. Now, it's not yet raining in California, okay, but it will rain this winter. And as I walk through the rain, if I have my blood pressure and LDL set at higher numbers, you can see up here, I will get some protection from that, no question about it. But if the wind is blowing in Sacramento, I'm going to get wet, at least from the waist down at that point. If I lower the umbrella, so we're going to lower the LDL down to under 130. We're going to lower the systolic blood pressure to under 130 at that point in time. What do I get? I get more protection at that point in time. I can walk through the rain in Sacramento without getting as wet. Better protection at that time. Now, there is a reality that if I pull it too low, I bump on the umbrella at that point in time. And there is a side effect from lowering the blood pressure under 130 in the trial, and that is a number of patients may have had syncope. If they have syncope, then we stand them up. We do back off of the therapy a little bit at that time. But if you have syncope, you've recovered 100% from it. You get up and you walk away. If you have a stroke, you're not 100% recovered at that time. And then MI does not necessarily go away overnight at that time. So what we have is a very simple way of doing it, and I thought to make it even simpler at that point, I would draw for you an emoji that we can attach to a tweet at any time. The emoji is pretty simple. It shows under 130 for both LDL and blood pressure is the way to protect your heart at that point. So this is the simple message. And lastly, one further message, it's important to start early with this. And in California, we looked at this, we had an increase of type 2 diabetes in school kids in California. An increase in obesity, it was going straight up. So we developed a program with the California Department of Public Instruction. We went in and we changed the diets in the school lunch program, which were 55% fat at the time. Changed those. And when we started out, there was zero exercise required in the school system of California. 0 minutes a week at that time. So what did we do? We changed the diet, revamped all of that, and today, in California, 6.3 million kids exercise 30 to 40 minutes a day because of the legislation we introduced and put into the school system today. That's more than any physician could do on their own at any time. And it shows the use of leverage that we have available. So we're taking these changes, we're implementing it. UC Davis is now looking at a high-risk clinic. Dr. Lopez is here, he's going to run that clinic to further reduce cardiovascular disease, to get even better targets than we had before, lowering those numbers but still staying within guidelines. That's our way of protecting and improving for the future. This is my short and brief presentation. Thank you for attending.
To power through our next two presenters, 15 minutes each, and we're going to break for lunch, and we're going to reconvene to hear from Richard Figueroa, who runs DHCS. Although I do see an awful lot of people walking out for bathroom breaks, I hope that we can just continue with the program as written, as they do connect with one another. So I just want to say that we are so lucky to have with us Dr. Stephen Sidney, who is our Lifetime Achievement Award winner. We'll be doing photographs later. But I think when you watch his presentation, you will understand why it's so important that we honor him. Because he has been running this study that was funded by the National Heart, Lung, and Blood Institute since the 1980s, looking at biometrics, including coronary calcium among the young. And his findings are truly world-changing. It will change the trajectory of how we prevent heart attacks and strokes going forward as the knowledge has become known. I have to say, until he emailed me last Thanksgiving, the article, I had no idea about this incredible knowledge, and I'm just so thrilled that he's here with us to share it.
He is the head of the research clinics for Northern California Kaiser and has been for decades, so we're honored to have his presence here.
Thank you, Patty, very much. Fortune, embarrassment, and all those things. So I am hopefully going to be able to speak in a manner that will keep you from thinking about how hungry you are right now. And I'm going to actually talk about two different topics, because one of them is fresh for me. I'm going to spend a few minutes on it in spite of Patty's imploring me not to really talk about it. But I think it will be news to you, and it's important news for this program. So let's see, there we go. First of all, the later you are in a program, the less you are, have to say. I think Dr. Short-Carroll has said what we need to say about Bernard Tyson. It's a great loss to Kaiser Permanente and to the nation. One thing, a very personal thing, he is shown here. He didn't show up all that often for research efforts. He showed up 3 years ago for a 30th anniversary celebration that we had for participants for the cardiac study. About 200 participants showed up at this event, and he made a beautiful talk for about 15 minutes, largely about his own personal history with coronary disease. And I think many of you know that he had a very serious heart attack when he was 45 years old, had heart failure. And well, nobody will say what he died from. He was asleep. I think we can all guess about that. The first part of this talk, this is the material that was published less than 3 weeks ago. You have two handouts. One is an article, one is a report for the National Forum for Heart Disease and Stroke Prevention, published for the meeting. This is a kind of a history of coronary heart disease mortality, rather, from 1910 to 2017. Why 1910? That's the first year when heart disease was the leading cause of death in the United States. It has remained the leading cause of death in every single year except for the flu pandemic years of 2018 to 2020. And you can see it went up for a long time, kind of reached a peak plateau around the late 70s, early 80s, and then has come down since then until what I think is going to be remembered as a historical year for heart disease, 2011. And you can see that since 2011, the number of deaths has been increasing. Here in the red, you can see the rate of decline. It was going very vigorously until 2011, virtually stagnant since then, just a 5% decrease since then. But in spite of the decrease, the number of events has been increasing, actually by 8.5%, by over 50,000 deaths. Why is that? Is it growth of the population? The answer is not growth of the general population. Here's 2011 to 2017 growth of 4.5%. So where does, we know it's a lifelong disease, heart disease in general, but where do the deaths occur? 80% of them occur in Medicare age group, more than 90% of heart failure deaths. And here's what's been happening to that population, and if you look over on the right here, this is the over 65-year population, In the last 6 years alone, that has increased by 10 million people, from 41 to 51 million people, 23%, projected to increase another 44% by the Census Bureau to 73 million by 2030. And that's the reason this is happening. Heart failure is even worse because rather than going down, it has been going up in that time period. Number of deaths have been skyrocketing. This is what PowerPoint does to you when you take it to another computer. But I just really want to point out that this is a 38% increase in the number of heart failure deaths. There's nearly 9% increase of heart disease deaths. Coronary heart disease continues to go down, went down 15%, but because of the population change, the number of deaths barely changed at all. This is the same article that Betsy Thompson talked about before, and this is focusing on the fact that it's not just the older age group, it's the younger age group. And I finished this section by saying this is what's happened to heart failure deaths as the underlying cause in the last 6 years, 50% increase. They will feed into the increase, and so I'm afraid getting to zero doesn't look really good right at the moment when the population is going up at about 3% a year in that age group, and the rates are all going down, and then we're going to continue to see increases unless something really dramatic happens on the prevention. Now, I will skip over this slide. I've more or less told you what's happening here. To move on to cardia. Now, cardia is a observational study, began in the mid-1980s. I was lucky that my career as an epidemiologist was just starting at about the time we were writing proposals for cardia. So I've been involved with the study since the day it was funded on December 1st, 1983. The other 3 centers are in Chicago, Minneapolis, and Birmingham, Alabama. It was about 5,100 participants recruited at these 4 centers, balanced with relatively equal numbers of people in the 18 to 24 range and 25 to 30 range. So it's a study of young adults. It's actually cardia stands for cardiovascular risk development. The relatively equal divided by sex, by race, by whites, and by education. This is, since it started, there have been 8 follow-up exams. Most recently at year 30, when we examined 71% of the surviving cohort, which is quite amazing when you think these are young adults and they've moved all over the world. I'm very proud to say that ultimately we saw 75% of our participants. Very briefly here, just to show you, we have actually, there should be about 500 deaths now, and most of them are relatively equally divided by cancer and cardiovascular disease. We have over 400 non-fatal cardiovascular disease endpoints, roughly equal numbers of strokes, and heart disease, a lot of heart failure, as well as atrial fibrillation. You've seen this picture showing the coronary artery calcification, and I'm going to talk about it a little later on among the speakers. So what have we done about this in cardio? We've actually measured coronary artery calcification in these individuals at 3 different time points, at their 15-year, 20-year, and 25-year follow-ups. What I'm reporting today is the study I published about 3 years ago, looking at the participants who had TAC, coronary artery calcification, measured at year 15, and which they were an average age of 40 years. pretty young adults in the cardiovascular world, and following them for up to 12 and a half years for cardiovascular events. At that time, the prevalence of CAC was 10%, basically through the cohort. Over 309 individuals had some coronary calcification. This is a cumulative figure showing, obviously, that most of the people had 0 scores, 150, 1 to 19, 98, 20 to 99, and 55 over 100. This is survival-free period for end-stage coronary disease. You can see the higher the score, the more likely that they will not survive through coronary disease. So it's quite a marked increase, almost 20% in those at this point in time for those with a score over 100. Now this shows odds ratios for the development of coronary heart disease events by coronary calcification score. These are all relative to 0, having no calcification. So you can see that having any coronary calcification gives you about a 5-fold increase of risk. 1 to 19, about a 2-fold increase. 20 to 99, about a 6-fold increase, and almost a 10-fold increase if your score is 100 or more. So that's basic results of what we saw. Now, the question is, how can you use this? We know, and Dr. Bonner showed very well, that it's not a great thing to have a coronary calcification, especially if the score goes high. But what do you do? And I think CARDI helps to inform what we might use as a screening strategy. Short of measuring coronary calcification in everybody who walks into the room, which has its downside as well, not the least of which is economic, even at a cost of $150 a scan. I think much of the thinking that's been going into this relates to how to combine cardiovascular risk with making a determination as to whether somebody should get a coronary calcification scan, with the basic question being, will this give information that will help us to decide whether they need treatment, i.e. statins, or not need treatment? So this slide basically shows that we divided the people up for this particular table as to whether or not they had above or below an average Framingham linear risk score. And what I want to point out here is that they had a high score above average. 64 of them, a lot of them had coronary calcium, but moreover, 64 developed actual coronary heart disease during that time period. If they had a low score, below average, they still were a chunk of people who had a positive score, but only 3 of them went on to have an event. So this suggests we're getting somewhere here. Now I want to move on to the next slide. This slide just to show you that 80% of our population was in the low risk group. Basically, they had no, they were under 4% Framingham risk. Again, these are pretty young adults, and very few of them, but a chunk of them had a very high cardiovascular risk. But we had a chunk of nearly 20% of the people in this intermediate risk category, 5 to 11%. So here's what happened when we looked at what happened to the events. Let's first look on the high cardiovascular risk side. Here it's pretty clear, no matter what their coronary calcification score was, and we'll go from left to right, from 0 to 1 to 19, 20 to 99, to greater than or equal to 100, they had a fair side risk of developing coronary disease, even in the lowest bar as 10% over 12 and a half years. So these are people you would think, going with the current line of thinking, these are people you're going to treat. Coronary calcium score measurement may not really add very much to that. You might actually, you might